The next genus we're going to talk about is Clostridium. And all 4 of the organisms that you see listed here are all high yield for the boards. Okay, we have the 2 neurotoxins in Clostridium tetani and botulinum. For Clostridium perfringens, we have gas gangrene, and for Clostridium difficile, we have now one of the leading nosocomial infections. So this is a very intense chapter with a lot of packed information that is highly testable on the USMLE Step 1. The entire genus are gram-positive rods, and here is one of the anaerobes that we're going to start talking about. Remember at the beginning we said anaerobes, A, B, C of anaerobes, and the C, of course, is Clostridium. Okay, so these do not grow in the presence of oxygen. They do form spores. So if you look at the image for Clostridium, you can see that these organisms looked different than the ones that I showed you for Bacillus. Sometimes they'll describe these as tennis rackets, and you can easily see that in the image when you look at those organisms because they have these terminal spores. Okay? Now, as far as for Clostridium tetani, the most important virulence factor clearly is going to be the toxin, and that's one of the important neurotoxins that we mentioned at the beginning. I also gave you kind of a scenario at the beginning of why your mom never wanted you to go outside without shoes. You step on a rusty nail, and you can get those tetanus spores introduced deep into the tissue. They would start to germinate and create vegetative cells that would then secrete the toxin. So that's a typical scenario of how you would get Clostridium tetani. And in addition to those puncture wounds, it's a good idea to remember that you can also get those from human bites as well. And in any of those situations, you would clearly prophylax, and that would be based on the history of vaccination and how recent that patient's vaccination was for Clostridium tetani, if at all. Now, again, as far as the pathogenesis and virulence, the spores get inoculated into the tissue. They create a vegetative cell that then begins to secrete the toxin. And what kind of paralysis do we say this was? We said this was a spastic rigid paralysis. So what we're doing is we're blocking release of inhibitory mediators, in this case, GABA and glycine. So you wind up with your excitatory neurons completely unopposed, which gives you those very painful and extreme muscle spasms. This is an extremely toxic substance. In fact, the toxin that you could fit on, let's say, the head of a pin could probably be responsible for massive death in a large city. So it's extremely toxic. The disease itself for tetanus follows kind of a sequential pattern where you typically start off with lockjaw. Okay, so the jaw begins to tighten up, and sometimes they call that rhizus sardonicus or the sardonic smile. It looks like kind of an evil grin. Then you start to go into those extreme muscle spasms. And at that point, it could be any stimulus that you are exposed to, from someone turning on a light, from someone just whispering in a room, can send you into those very painful muscle spasms. In the case for diagnosis, most of the time the symptoms are fairly straightforward. Now I'm going to give you an example. I actually had a student in the last couple of years that actually got tetanus. Okay, he cut himself with a kitchen knife. He went to the ER to get it stitched up. It was a pretty deep cut, and instead of doing the stitching, they used that Dermabond. So what it did was it sealed up the wound and created an anaerobic environment. So the spores got in there, they started making the toxin. And at that point, he was in his second year of medical school, and he was vaccinated, but apparently it wasn't extremely recent. So his jaw started hurting him, and then his back started spasming. And he goes back to the ER, and he says, they said, what's the problem? What seems to be the issue? He said, well, I think I have tetanus. They're like, no way you have tetanus. Do you know how rare tetanus is? And he's like, okay. So he leaves the ER. The spasms get worse. Goes to an infectious disease doctor that actually diagnosed him properly. Now, the reason I bring up that case is to talk about, again, I'd like to move in a little bit to the treatment, but the treatment for Clostridium tetani is going to involve antibiotics and an antitoxin, okay? So they administered both of those. He had antibiotics, he had the antitoxin, and the antitoxin only works for free toxin that's unbound, okay? So any toxin that was already bound was going to continue through its half-life, which was several months actually. So he actually had very painful muscle spasms right around the time he was supposed to take step 1. So it does happen, and you got to be on top of that stuff in case you do have a case like that, where nobody in the world would have suspected that a medical student who clearly was probably up to date on his vaccinations was going to be positive for tetanus. Okay? Let me show you a couple of the pictures of things that we've talked about. In this image where you see the man's face, basically, that's Rhizus sardonicus. That's a sardonic smile. And the image on the right-hand part of the slide are the muscle spasms. That's very, very characteristic for tetanus. In fact, long time ago when people used to, draw things on the walls, you can actually see the drawings of people that have that kind of arched back and very kind of spastic appearance. So that's classic tetanus, okay? So that's why a lot of the times it's made, the diagnosis is simply clinical, okay? Now treatment. We talked about treatment already, but just to kind of go over it again, you're going to give antibiotics to kill the organism. And this is a case where we actually have immune globulin that we can give to neutralize the toxin, okay? Again, it can only neutralize free toxin. It can't neutralize toxin that's already bound. So that's going to have to go through its normal half-life. One of the other things you can do is you can give spasmolytic drugs to help control some of the spasms. And again, we're talking about anaerobes here, okay? So to delay closure of the wound. So what happened in the case that I told you about was they not only didn't delay closure, they sealed it up, made it an anaerobic environment. If you can delay closure of that wound for as long as you can, that exposes it to the oxygen and the organism can't grow. So that's also a good way to manage and help prevent actually tetanus. Now, this is one of the agents that we do have a vaccine for, okay? And remember I told you when there was an organism that we could cover through vaccination, you had to know the vaccine and what type it was. So in this case, this is part of the DTP vaccine, and it is a toxoid vaccine, which means it's tetanus toxin that's been chemically inactivated so that it no longer can cause disease, but we didn't denature it with heat because that would undo all of the antigenic structures of the toxin. So it's chemically inactivated. So vaccination is really important. We try to vaccinate every 10 years to help prevent tetanus, which is why in the U.S. tetanus is actually fairly rare, okay? But still very testable subject on the USMLE, so you want to pay attention to this one. All right, on the flip side, we just talked spastic paralysis. Now we're going to talk flaccid paralysis. Clostridium botulinum causes a flaccid paralysis. How might you do that? In this case, it's preventing the release of acetylcholine, all right, which is going to create that flaccid paralysis. So it's essentially almost opposite of what we saw with Clostridium tetani. In the case of botulism, predominantly the transmission is foodborne. You can get it by traumatic implantation, but we're really not going to discuss that because they're testing this on the USMLE. They're going to ask you either about floppy baby syndrome or they're going to ask you about adult botulism. Okay, so traumatic implantation, which you can see in IV drug users, we're going to not really focus on. We're going to focus on the foodborne transmission. Okay, remember, Bacillus and Clostridium have spores, so spores are always going to be an important part of the pathogenesis for Bacillus and Clostridium. So in this case, the spores survive in the soil, in the dust, for a long period of time. When they get inside, let's say, canned food, home canned food for the adult botulism, or if the spores get into honey or something like that in the case of infant botulism, then we either worry about them secreting the toxin or actually initiating an infection. But the main virulence factor that you need to worry about here is botulinum toxin. Okay? Again, it's one of those classic AB toxins, and in this case, we're causing a flaccid paralysis, so we're actually blocking the release of acetylcholine. Now, later on in Chapter 3, we're going to be talking about some of the mechanisms of gene transfer in bacteria. And one of the ways that they like to throw in questions on gene transfer to make them clinically relevant is they might give you a case of botulism and then ask you by what mechanism the organism acquired that toxin. Okay? In this case, it was actually by a bacterial virus called a phage. We're going to talk about transduction in Chapter 3, but just kind of keep that in mind as we go through and how they can ask you those types of scenarios with a more clinically relevant question. Now, what did we say about Staph aureus toxin? Is we said it was heat stable, so you cook that and the organisms die, but the toxin stays intact. You ingest the toxin and bam, you get sick right away. Okay? With botulism toxin or botulinum toxin, the toxin is heat labile, meaning if you actually heat your food, you can inactivate the toxin. Okay? So in that way, it's a little bit different from Staph aureus. Okay? So here's the example I give the students. I say, okay, we know you're all on a budget, so you go to the store and you see chunky soups on sale 5 for $1. That's unheard of, right? It's an NFL size hunger, 5 for $1. And you see that one can and it's just bursting at the seams. It's all bulging out the sides. It's about to blow. You look at that can and you're like, wow, I'm getting more for my money with that can. I think I'll take it. So you buy that can of bulging chunky soup. You bring it home. The very important part here is that if you heat it for 10 minutes, if you boil it for 10 minutes, you'll inactivate the toxin and you won't get sick. If you're super hungry, you nuke it for a couple of minutes and then eat it, you're probably going to get botulism, okay? Because heating it for 10 minutes under a, high temperature is what you need to actually inactivate the toxin. So you need 10 minutes of boiling. Microwaving's not going to cut it. All right? Now, you'll see on this table the 3 different forms of botulism. And again, as I mentioned, we're just going to focus on adult versus infant botulism. And while the symptoms can be similar, the way that you get them is very different. So we're gonna definitely discuss some of those differences. All right? Now, as far as the adult form of botulism, this is from canned food or probably even more common, home canned food. All right? What happens is in home canned food, you get the spores in there, and then what do? You seal it up in a mason jar, and it can be good for a year, okay, or more. Well, you've created an anaerobic environment in there, which is perfect for Clostridium botulinum. So what happens? The spores germinate, make vegetative cells, start making the toxin. So now, let's say you made something that maybe wouldn't require heating, and you go to eat that. You made salsa, for example. You go to eat that salsa a little bit later, and you're ingesting pre-made toxin, okay? Now, that is in contrast to what happens with infant botulism, okay? In infant botulism, the infant is actually ingesting the spore, okay? Now, how that's different is that we've just gone from the adult botulism, which is an intoxication, to infant botulism, which is a true infection, okay? So what happens is the infant will ingest the spores on honey, is very common, so you know that's really kind of a buzzword for infant botulism. They ingest the spores, and an infant's gut doesn't have near the normal flora of our gut, okay? We talked about that with normal flora. And the infant's gut's really just starting to get regulated, starting to get going. A spore doesn't have much trouble germinating in the gut of an infant because there's not as much normal flora. So they ingest the spores germinate, and then start secreting the toxin. So in both cases, the disease is due to the toxin. In adult botulism, you're ingesting the toxin directly, and in infant botulism, you're ingesting the spore that turns into the bacteria that secretes the toxin. Okay? So, moving on, symptoms again, very similar in the adult. Again, remember we're talking a flaccid paralysis. A lot of the times this may start with kind of blurry vision. You have the flaccid paralysis, and it can actually affect the respiratory muscles. It could get so bad you would have to go on a respirator. Now, in the case of infant botulism, it's very similar, okay, but the symptoms in an infant, a little bit more difficult. You know, they're not going to say, Mom, I can't see, my vision's blurry. So the things you're going to have to pick up in an infant are the fact that they're really not eating well. Their crying has gone from a wah that rocks the house to like a little tiny baby cry. And we call this floppy baby syndrome. So you have the flaccid paralysis where the kids really just can't move. So the situation here with infant botulism is something like this. In the vignette, they'll say something about, you know, the parents of a 4-month-old baby were distressed because the baby seemed colicky, nothing could quiet it down, and someone suggests they dip that pacifier in some honey and give it to the infant, and they're sure that this is going to work. And you know what? It does. It works so well, the baby stops eating, crying, and moving. All right? So it works way better than they ever intended. All right? So you're going to see that probably in the vignette. If you don't, what they'll mention is that you have this baby with the symptoms that you see right here, okay? And then they will ask you what activity led to the symptoms in the above case. And typically they're going to ask you about the ingestion of honey, all right? Now, where will you find the toxin for adults? You can go back to the food, that home canned food. In infant botulism, you can find it in the stool or the serum. Treatment for botulism is going to be different a little bit between the adults and infant. Adult botulism, remember, is an intoxication, so it does not require antibiotics. And whenever you have a case like that, I guarantee they're going to ask you a treatment question, and they're going to load it up with antibiotics. And you're going to be so tempted to pick them because you're like, man, they can't breathe, they can't move, they can't see. I got to do something. But they don't have an active infection, and that's what you really have to watch out for. So in this case of adult botulism, what you're going to do is you're going to give antitoxin, okay? Now, the antitoxin does not cover all of the strains of toxin, but that is what's indicated for treatment of adult botulism. If you go over to infant botulism, okay, if there's respiratory arrest, they'll have to clearly go on a ventilator. You can also give hyperimmune serum to neutralize the toxin. But I want you to look down at the bottom where it says antibiotics generally not used as it may worsen or prolong the illness. Now, why we really focus you in on virulence factors and such is because if you don't know that botulism has a toxin, okay, you might just treat with antibiotics. And what are the antibiotics going to do? Well, antibiotics are typically going to lyse the bacterial cell. All of that toxin is going to come out, and what you could do by giving antibiotics is, instead of making the patient better, you could send them into a toxemia and kill them. All right? So you really have to be careful. So in a case of botulism, and I'll skip ahead and just tell you, in enterohemorrhagic E. coli in a child, you're not going to give antibiotics for that very same reason. All right? Now, we go down to prevention for adults, proper canning, and again, in the example of the store-bought canned food, it's going to be that bulging can, which is an indication that you have bacteria replicating in there, and that's the gas production from the bacteria that you're seeing in that bulging can. In the infant, of course, it's no honey. And again, when they ask you that question, they could be asking you the diagnosis, they could be asking you about the toxin, or they could be asking you about the suspect food, okay, for botulism. But all in all, that's going to be a highly testable subject for step 1. All right, we'll move on to Clostridium perfringens. Clostridium perfringens we mentioned as a causative agent of gas gangrene. These have a couple of distinguishing features that maybe set them apart from some of the other members of the genus. First of all, if you culture these in something called milk media, again, without oxygen, when you look at that tube the next day, it's going to look like a thundercloud in there. So we call that stormy fermentation. So that is one of the distinguishing features for perfringens. Also, we've talked about hemolysis, and we know, for example, that Group B strep, Group A strep, Staph aureus are all beta hemolytic. If you culture Clostridium perfringens, again, without oxygen on a blood agar plate, you'll see 2 zones of hemolysis, okay? So that's a double zone of hemolysis. That's also very characteristic for Clostridium perfringens. The normal reservoir for perfringens are the soil, and they also can be normal flora in the colon. Therefore, you're typically going to get them from traumatic implantation or foodborne transmission, okay? Now, clearly, the most testable as far as perfringens is going to be the traumatic implantation, all right? Even though perfringens causes food poisoning, it's actually probably more common than we think. If they ask you about perfringens, they're more than likely going to ask you about gangrene, all right? And clearly because of the high mortality rate. Now, when we were talking about toxins, okay, we talked about the cyclic AMP-inducing toxins, the toxins that inhibited protein synthesis, and we talked about the cytolysins. And this is one of the cytolysins I mentioned that was actually very important, okay? Perfringens produces several toxins, but it's actually the alpha toxin that gives you the actual symptoms that you see during myonecrosis or gas gangrene. Now, as far as identifying Clostridium perfringens, there is a diagnostic test to look for the toxin, and it's called the Nagler reaction, where you can culture the organism on an egg yolk agar plate. In that plate, you would have one side that has the antitoxin in it, and one side that does not have the antitoxin. And in this case, you're actually detecting the side with no antitoxin. So you can actually see that lecithinase working in that egg yolk agar plate. Now, down at the bottom, they're talking about the enterotoxin for when Clostridium perfringens is found as an agent of food poisoning. And again, we're not going to probably see that on the exam, all right? More than likely, if they test about perfringens, they're going to be asking you about gangrene. So let's look at gangrene or myonecrosis. I'll give you a little scenario of how this is probably going to show up, but almost always when they're giving you a case of gangrene, it's a very traumatic accident. So we're talking a car accident, maybe an ATV accident. And one of the key things that might be in there is the patient or the injured person does not get help right away. So they're sitting out there, they've been injured. If they're in a car, they're trapped in the car. And what happens is you get contamination of their very traumatic wounds with either soil or feces. And what happens then are the spores are going to begin to germinate, are going to begin to make toxin. And the toxin, again, is the alpha toxin for Clostridium perfringens. And that alpha toxin is what gives you these very classic symptoms of the myonecrosis, where you've got the very tense tissue. If you were to palpate it, it's very edematous, full of gas. And what we always worry about with gangrene or myonecrosis is, of course, the systemic symptoms, which include the fever, tachycardia, etc., because that can very rapidly lead to death. So we know that myonecrosis has a very high mortality rate. Food poisoning, again, I doubt this is going to show up, so I'm not going to spend a lot of time really talking about gastroenteritis caused by Clostridium perfringens. But in a case where they mention perhaps that the patient ate some leftover meat, then you might consider perfringens. But again, I really doubt that's going to show up on step 1. All right, as far as the diagnosis for gangrene, usually made by way of a clinical, very easy to pick up. Now, as far as treatment, you've definitely got to do something pretty quick, because as soon as it goes systemic, that's when we really worry about the patient dying. But as far as treatment, we're going to give antibiotics to kill the bacteria. What we can do that's very helpful, again, just like for tetanus, if we can delay closure of that wound to let it get exposed to as much oxygen as we can without clearly risking the life or limb of that patient, that's also a good mechanism of treatment. Additionally, you can expose that patient to hyperbaric oxygen, again, because the organism cannot grow in the presence of oxygen. Treatment for gastroenteritis, as we're going to repeat over and over for most of the things that cause gastroenteritis, is self-limiting. So you're just going to kind of let it run its course. Now, prevention, of course, is debridement of the wound pretty quickly and prompt administration of antibiotics so the organism can't really start to grow. That's why I mention, because if you can do those preventative things, you're not as likely to develop gangrene. That's why I mentioned in the vignette, they may talk about someone that had a traumatic accident that couldn't get help for a while, so they wouldn't be able to use those preventative measures. The last of the Clostridium on the list is Clostridium difficile. Okay? This is normal flora in the colon and the GI tract. Therefore, when we discuss transmission, we're talking endogenous transmission. Now, the virulence is associated with toxins, and this is really interesting, okay? When C. diff is part of your normal flora, it is kept in control and kept in check by the millions of other species of bacteria that you have in there, all right? Now, what happens is you're prescribed for, let's say, a UTI, broad-spectrum antibiotics. And we know with broad-spectrum antibiotics, we're going to be killing off a lot of that normal flora in the gut. What happens is C. diff is resistant to some of those broad-spectrum antibiotics. So C. diff all of a sudden is like, whoa, look at all this room I have, and starts growing. And when it starts to grow in high titers like that, it starts to make the toxin. And it's the toxin that really is the precipitation of pseudomembranous colitis in this case. It's toxin mediated. So the disease is antibiotic-associated or pseudomembranous colitis. They may mention these yellowish plaques on the colon if they look at that. If not, it's going to be a classic vignette where somebody had a UTI, they were given broad-spectrum antibiotics, and they started with this kind of voluminous diarrhea. You do need to know the antibiotics that are commonly associated with Clostridium difficile, and the ones that we have listed here are probably the most common, being the cephalosporins, clindamycin, and amoxicillin and ampicillin. Sometimes they'll give you that vignette, okay, and they may ask you which antibiotic that patient may have been taking. Okay, now the diagnosis for C. diff is a little bit different, so we're going to have to talk about diagnosis here. A lot of the times when you have a patient that has diarrhea, clearly you can culture that and find the causative agent, culture and gram stain. In this case, you could culture it, but I guarantee you're going to find it because it's part of the normal flora. So that's not going to tell you anything. So what's really important here is that you actually have to do a toxin assay. You have to look for the toxin in the stool. So you will look for the toxin, which is an indication of that pseudomembranous colitis. Again, you're not going to culture the organism because you will find it. It's part of the normal flora. The toxin is the indication that the rest of the flora got killed off and C. diff is really kind of flourishing. Now, as far as the treatment goes for C. diff, a couple of different things you can do. If it's mild, maybe just at the kind of the beginning of it, you can really just discontinue that broad-spectrum antibiotic therapy. And what's going to happen is, as soon as the gut begins to rebuild its flora, you're going to take care of the C. diff problem. Okay? But actually what we're seeing more and more now are the more severe disease with C. diff. It's becoming one of the leading nosocomial infections. Lots of hospitalized patients are getting C. diff now in the U.S. And in this case, what you have to do is not only discontinuing those broad-spectrum antibiotics, but you have to go with an antibiotic to which C. diff is susceptible. And in this case, it's typically metronidazole or vancomycin. So that's what you're going to do if it's very severe. And that's probably, if they're giving you a vignette where the patient's having this voluminous, kind of greenish diarrhea, they tell you about the plaques, you're probably then going to go with treatment with metronidazole. As far as prevention, I'm not sure it's even worthwhile to talk about, but limiting the prescriptions for broad-spectrum antibiotics and the overuse of the broad-spectrum antibiotics is really kind of what you need for the prevention of C. diff. All right? So those are the 4 Clostridium that we talked about. All of those are considered high yield for step 1 of the USMLE, all very easily testable. But we covered vignettes for pretty much all of them, so you should be able to pick those up pretty quickly.